talking about extracorporeal life support and really focusing on the neonate and the pediatric, although I will be saying a few words about adult extracorporeal life support. I have no financial disclosures. And again, this talk will be focused on the use of an extracorporeal system. This is just a schematic of a newborn on a veno-arterial Ecmo, where again we drain blood from the right heart into a pumping system. This blood is then pushed through an artificial lung and returned in the baby through the arterial system where they can get bypass support for both the heart and the lung. So in my talk, I want to go a little bit through the history just to show you where we are today and what we've learned from our past, and also the populations that are being treated today and their outcomes, and some of the equipment changes, and then what the future holds for extracorporeal life support. A little bit about terminology. Ecmo is a word used to talk about extracorporeal support when you have an oxygenator in line, a membrane oxygenator. So it's a typical term that's used very often. But if you're going to be using it for other supports that are either cardiac or respiratory, you probably want to use extracorporeal life support, and this includes ventricular assist devices like the Berlin heart. It does include Ecmo, and I'll at the end talk a little bit about Ecmo without a pumping system, but just with the membrane. The other terminology you will see in the literature is ECPR, and this is the use of Ecmo for a patient who's coding. And in our unit here at Children's in Washington, this is primarily used in the cardiac unit for post-op cardiacs who go into acute pulmonary hypertension crisis. They can be placed on the circuit very quickly. It's a modified circuit design, so the setup is actually these units are already set up and ready to go. The surgeon just needs to place the catheters. Pumpless Ecmo is now in the adult arena, and I'll talk about it at the end. This is capable of not using a pump in line, but just the membrane in line. And I'll show you how that's done at the end of this talk. But it is potentially something that can be used in smaller patients with the membranes that we have now that are very, very low resistant membranes. So you can go through an artery and a vein, just similar to some of the renal dialysis work, and oxygenate with these systems. I think you'll see these being developed more in the next few years. A word of the history. This is the first, really, in the United States extracorporeal life support survivor. And this is the membrane lung down here, very large one, very different than today. This gentleman was in a car accident, actually had a ruptured spleen and went into ARDS, into respiratory failure. But he really, having this success, there were several programs around the country that started treating some adults with some good outcomes. And when in the 1970 era when the swine flu hit, there was enough cases of this Ecmo being used in adults for the National Institutes of Health in the United States to fund a randomized controlled trial of ECLS versus mechanical ventilation, hoping that this would improve outcome during this flu epidemic. Interesting, during that time, that President Ford did issue nationwide vaccinations, which is a controversy in many places. This study, unfortunately, did not show an improved outcome within the adult population, but had many, many study design, I think, that really did not allow it to have a good outcome. The 9 centers in the study, only 3 had ever done ECMO before, so you're putting the most complicated patients on a system that with a team that really had not trained on it. They also stopped ECMO very early. As you can see, most of these patients came off within the first week, and most of them died, unfortunately. And as we know today, with many studies now showing improved survival in the adult population, that they need to be on a minimum of 2 to 3 in some of these weeks, but some of these patients are on 2 to 3 months before they see improvement in lungs. So this study really didn't answer that question. Unfortunately, it stopped some of the research in the adult population because of the outcome of this, but it is now very routinely used in adults, and actually with the COVID pandemic across the world right now, this is the Extracorporeal Life organization, which most ECMO programs belong to and put their data into, has a ongoing count on the COVID patients. You can go on their website. It's actually available even if you're not a member to see this. This was this Monday. There were close to 10,000 COVID patients that had gone on to ECMO, with about a 48% survival rate across the world. And so it is being used. It is a limited commodity because it takes a lot of people to run an ECMO circuit and a lot of equipment, so it's not available everywhere. But when it is available, it is being used on the COVID patients. Just again, a quick advertisement about ECMO centers. This is from the ELSA database, and the number of centers around the world are pretty extensive. The other arm, because I'm a neonatologist, was the use in the early 60s, trying to use a artificial membrane. This is a silicone membrane on premature babies to try to replicate the placenta. And this was done actually in our hospital by Dr. Avery at the time. They were using the umbilical vessels and going arterial venous, and actually didn't have a pump. They could oxygenate, remove CO2, but unfortunately the heparinization, coagulation problems, and these preemies caused all of them to have major intraventricular hemorrhages. So the really attempt to use it as an artificial placenta at this time was stopped. And fortunate for us, Dr. Bartlett, who's we consider as the father of Extracorporeal Life Support, who had trained in Boston when they were developing many of these systems, and then moved to California, and actually was setting up the adult program for that NIH trial when he talked his neonatologist into treating this baby who had meconium aspiration syndrome. And when I looked, he wrote up this case recently to remind us her oxygen level was 20 when she went on this circuit, and obviously made it off. And what really turned the whole field around, showing that if you treat the right patient population, you actually can have a very good outcome. He published a paper with 40 children after that, mainly meconium aspirations, who had a 70% survival with predicted survival of 20%. This little girl's name's Esperanza, and this is she. We had a large conference in Ann Arbor in 2019, and this is Dr. Bartlett, who's still very active doing research. He's not doing surgery anymore, but doing research in extracorporeal support, and actually designing systems that can be worn like the artificial heart. These will be artificial lungs that people can clip on and walk around. That's where his research is going, and we'll see hopefully some of that in the future. And Esperanza doing quite well, and a lot is talking about how she survived. When you look at the ELSA data, and this is up to December of 2020, and today I looked at the number. We have 167,000 patients in the registry. The neonatal population is divided the way they look at data. In our respiratory kids, about a 70% survival to home. This used to be higher. Used to be around 80%, but we now have many new therapies that are keeping the less sick kids off of ECMO, and so the ones going on tend to be sicker. Our cardiac patients sit around 50%. And again, you've just seen two outstanding presentations on the complexity of congenital heart disease and, not just lung problems, but the repair types and reason. And I'll let John comment on that in the discussion phase. ECPR, again, in most places, this tends to be the cardiac patients who have usually post-operatively a pulmonary hypertension crisis and need to go on ECMO and other reasons. So the pediatric population, again, to home, about 67% survival, cardiac a little bit higher, and ECPR around 43%. The adults are, again, sitting about like our pediatric kids, about a 60%, a little lower than the neonatal respiratory patients. And the change over time is quite interesting. This light blue is the neonatal respiratory cases that used to be the big patients going on ECMO. This has changed, and now we look, the adult pulmonary patients are really taking over. And if you look down at 2020, the change in adult respiratory is all due to COVID. The significant increase with COVID population across the world. The pandemic is a big effect on this. The neonatal cases have dropped dramatically, and this is due to changes in treatment. We now have surfactant. We used to, early on, had 34 to 36 weekers that would need to go on ECMO, and now we can keep them off if they have a degree of surfactant deficiency, high frequency ventilation, and nitric oxide, again, a big player in keeping our newborn kids off of ECMO. So there's pretty big changes in the populations. So if you take away the adults, this is the pediatric and neonatal, both respiratory and cardiac patients. Down the pediatric respiratory chain have stayed pretty stable, while neonatal is decreasing. At our institution, we do a little over 50 patients, and 60-some% are cardiac. Again, we've dropped. This used to be the opposite. If you about 15 years ago, you would see this being neonatal or cardiac and pediatric, but this is, again, due to treatments that we have available for neonatal respiratory disease. The registry, again, has great data. The neonatal respiratory cases are sitting in around 800 a year now in the registry, where, again, they used to be around 2,000. So that's an interesting change. And the type of newborns going on, respiratory newborns going on, are, again, has changed over time. The light blue down here is the diaphragmatic hernia, which has stayed pretty stable. Meconium aspiration, again, has decreased because of nitric oxide, and I think is the main factor. And pulmonary hypertension also decreased because of nitric oxide. And we have its big other group. When you look at survival, and the other group, again, is a large number now. These are very complex kids that have other diagnoses. This is like the hypoxic ischemic brain injury kids that develop pulmonary hypertension, and some of the pulmonary atresias, different kids that don't fit the regular diagnostic categories. The diaphragmatic hernias now are one of the major numbers. They still sit around 56% survival. That really has kind of stayed in the 50 to 60%. The diaphragmatic hernias that do not go on ECMO, you have, of course, almost a 90% survival. So if you look at an institution's diaphragmatic hernia survival, it will usually range around 70%. But if they go on ECMO, it's about 50 to 60%. Meconium aspirations, the best outcome. They do very well. The ones that don't make it are not due to respiratory failure, but usually due to a neurologic complication. They've usually had severe hypoxia before going on and can develop brain hemorrhages. The same with the pulmonary hypertension. These kids Again, you can reverse their lung disease, but if they have a neurologic problem, those are the ones that don't make it. And sepsis and pneumonia are, again, less and less patients for us. The pediatric group, again, you have these diagnostic categories, and then there's a large group that don't quite fit these categories, but the viral pneumonias, about a 60% survival, bacterial about the same, and ARDS, these are a little different category of respiratory failure, not secondary to pneumonias, and about a 60% survival in these kids. Equipment changes. The equipment looks very daunting, but it's really changed a lot. This is some of the older equipment with a whole Ecmo system here, and the Prisma, which is a dialysis equipment you can hook in and do dialysis in, and cardiac support. This little baby up here is actually a post-op cardiac patient who's needing both cardiac support and renal support. But there's two pumping systems that people have to choose from. There is a roller pump, which many centers use, and then there's the centrifugal pumping systems. The roller pump has potential, which it's these rollers that go around and push blood out, of having some complications. If you obstruct the outflow catheter, which is the arterial catheter going back into the patient, you can actually blow the circuit up. And this is a picture of that, a patient at our institution that was being moved to get an x-ray, and the arterial catheter was kinked, and it blew the circuit up. The team is trained very quickly. We're able to get this patient back on ECMO. It took longer to clean up the wall. So that's why many people went to the centrifugal pumping systems, which had impeller blades that rotate. They will not be, if the occlusion that happens on the outflow, they do not build up enough pressure to blow the circuit up. They will just stop rotating. And they have been used in cardiac surgery for many, many years. And ECMO just really recently, or not recently, but in the last 10 years, converted over to centrifugal pumps. There's a lot of centers, though, because you have more hemolysis and a little more clotting problems with the centrifugal pump for babies, have gone back to the roller pump for babies and stay with the centrifugal for bigger kids. These are the systems available in the United States, and I think also worldwide. There are various different designs of these centrifugal pumps. We're using the Spectrum in our institution. And the problem is all of these pumping systems were designed for adults, and it's hard to get a company to really design for a neonatus. As you saw, it was only 800 cases a year in the neonate group. So when they designed these, they're designed to flow at 2 liters and on up, where our babies are flowing around 500 and down to, when we idle, we're about 80 cc's of flow. So we're way down here. You can see the hemolysis increases with decreased flow rates. Works very well in bigger kids with decreased hemolysis. But the baby end of it is a little bit of a higher risk, and that's why some centers went back to roller pumps for their infants and then used the impeller pumps for their older kids. We have had fairly significant success with our coagulation management in using our centrifugal pumps, so we've stayed with these pumping systems that we have presently. Membranes, the cardiac surgeons and the perfusionists have used this type of membranes for many, many years. These are hollow fibers with small little holes that have very good gas exchange for the time that surgery happens. But if you use it long range for ECMO, which is days, then these little holes, the albumin starts coming out of the plasma. And this is just one we tried to do on ECMO because of the heparin bonded system. So we really didn't get a good membrane until these polymethylpentane hollow fibers that don't have those small holes. They're just a very material that transmits gas exchange back and forth very effectively. And these are now used routinely across, I think, the world. And there are some other membranes that are available in Europe and especially in Japan with some very nice smaller membranes. These are the ones we have available in the United States, in the Quadrox, both an adult size and a pediatric size. And the Meadows highlight, I think, has been used in Europe extensively, and it comes in 4 different sizes. The nice thing about this low-resistant membrane and a centrifugal pump, it's great for transport. You can make it into a very small system to transport patients. And our hospital does have a transport team who've picked up cardiac patients that were, as Dr. Junaid said, born but weren't diagnosed prenatally and needed acute placement on Ecmo and transported to our institution. This is our present setup. And again, this is the pumping system right here, the centrifugal pump. And this is the membrane. This is the adult size membrane. A water bath that actually warms. You want to put the blood back at warm temperatures. And then a controlling system that actually controls the pump. And the one we have has a lot of functionality with our medical record system, so you can keep different labs and everything in this system. This is a patient being placed on Ecmo on this side. This is the pediatric membrane on this system. And again, this is the spectrum pump that we use. Actually, blood is coming from this direction down through the pump, through the membrane, and then back to the patient. And just another picture of the system and what it looks like. This particular company has both a centrifugal pump and actually has a roller pump. So there is an option if you want to use a roller pump with this system. And the controller panel is really a big computer that helps monitor the pump flow, the pump pressures, but also you can download from your medical record. From your electronic medical record into here to keep many of your labs and things and correlate some of the changes in labs and flow. So a quick review of these low-resistant membranes, and this is the use without a pump, mainly in adults right now, and using an arterial catheter and a venous catheter, so AV, Ecmo, and it's being placed in the femoral artery and vein. So you don't need a pumping system. You can actually put these patients on fairly early. There is a nice paper that just came out with COVID patients being put on this system instead of being placed on the ventilator, and they had a tremendous improvement in outcomes. So this is some of the direction I think will be happening over the next few years. I think early intervention, not waiting for these patients to be almost meeting death's criteria, but putting them on early, decreasing ventilator damage, and going there. This is the Berlin heart with the lung. Just a paper on that I thought was quite interesting. And the bridge to transplant now. This is, again, some of the low-resistant membranes, and this patient is on PA in LA circulation system, and what the adults are doing. Our adult program over at George Washington University is very active in this. They place these patients in an AV system, and then they get them up and walk them around the hospital. They found that this is much more efficient than having them in bed and having them on high sedation. They want them up and walking around. And then these are bridging to lung transplant these patients. Just another example of how you can do this. In the Swedish group, for many, many years, have kept their pediatric patients totally awake on ECMO and feel like they have better outcome by not having heavy sedation. What about we neonatologists? We can put this nice, low this membrane in line and create a placenta again. All of that stopped, obviously, back in the 60s when they had tremendous bleeding problems. Now we have really modified how we do our coagulation, so this is something that's coming up again. This is Dr. Kolabo, who designed the first membrane lung. And St. Paul did research trying to recreate this placenta back then in the lambs. They could do it, but they had a lot of complications, so this research didn't go far. But it is now back. Again, this is the 1960 work that again didn't have the best outcome. But we have two centers in the United States that are doing artificial placenta research again and having in animal models fairly good success. And this is the University of Michigan, and Dr. Michaelewski has a lamb model of Ecmo, so delivering these lambs prematurely, putting them on an Ecmo system and supporting them, and has ended up going to a VV Ecmo support from a VA. This was his original model with the umbilical vessels, but he did find that it created a fairly large shunt that the blood pressure was a problem in the lamb. Now he goes VV through a neck cannulation for these lambs. This is his setup. He shared these slides with me. The group at CHOP in Philadelphia, Dr. Flake, has very extensive research in this area and is using the umbilical vessels for his system, and has really taken this quite a ways down the road, and has companies interested in potentially making this a commercial product in the next several years. So I think we neonatologists, you may see some of these systems in the delivery room for premature babies, just placing them on a system. It still needs a lot of work, but this is where we're going. And just a word, they do grow up and do well. This guy right here, actually not a little guy anymore, but he's works on Capitol Hill, and he was a meconium aspiration patient. And she is now a pediatric hospitalist, trained, finished her medical school. She was a diaphragmatic hernia patient. This guy, I just put this in to show you, the scar can be revised by plastic surgery if the patient so desires, but he's now a lawyer and doing quite well. So I'm going to end and just invite you all. We do have our conference, which is an Ecmo meeting that we have put on for several years, and it's going to be both in person, we hope, if COVID behaves, in February, also virtual, so you can sign up for either virtual or come and ski with us in Colorado. Well,